here to hear Dr. Olin. And okay, so disclaimers. Everything shared here is for educational purposes, but you should consult with your own physicians about on this video. Each person the registry is a little different, and some things may apply to patients that do not apply to others. And we've just got a few disclaimers on here about Zoom. It's not HIPAA compliant, but that's why we cannot see you guys. And so that was done intentionally so that we are hoping to make the recording available to those who could not participate. And so this way they'll be able to see any of the patients, although names up because of the chat. So just so you are aware, your names may be visible. And this is just about the recording. It's pretty much everything that I just said. Hi, Martha. And so before Dr. Olin starts his talk, I just wanted to share this. I'm not speaking, but it's one of my favorite slides. 17 years ago, what we knew about FMD is very different than what we know now, and Dr. Olin will discuss that. But when I was diagnosed 20, there was no organization. And so FMDSA was formed in 2003, and we used to actually meet at a kitchen table in Hudson, Ohio. I'm from Ohio as well, and two of the founders lived. And the first physician that met with us was Dr. Beagleman, and she got Dr. Olin involved. Dr. Beagleman left, but Dr. Olin and I are the two original people that have stuck around, and everyone else has kind of moved on, and we've recruited new people. But anyways, this picture from 2018 is from Belgium, and you can see that we went from just a few of us at this kitchen table, really knew what to expect or where we were going with this. And so many patients get diagnosed. You can see we have research all over the world now focusing on FMD, and it's very exciting. Here, Olin, your speaker for today. And I know a lot of people don't have the opportunity to attend our meeting or be able to see him in person, but I can't say enough about him. He's amazing. He's our rock. And, he's really the leading specialist in the world on FMD. So Dr. Olin, thank you for spending your evening with us. We appreciate it.
You're quite welcome. So should I share my slides now, Pam?
Sure, thank you.
Okay, let's see. Hello, everyone. This is fantastic. I was looking at the chat and I see a bunch of my patients from California, and I see there's some people from Australia and South Africa, and it's just incredible that we can do this. This is the view I have from my office. I'm one of the lucky people who actually have a window in their office in New York City. What I'm going to discuss is how I got into all of this and how, as Pam alluded to, many of the things we thought were true are actually not true. And that this is complicated stuff, that it's not just easy to figure out what the cure or the cause of a very complicated condition is. So it's interesting. In 1938, Ledbetter and Birkeland first described this in a 5-year-old African-American young man. And he had malignant hypertension. And they took his kidney out and his blood pressure was cured. This is just a pathology of what it looked like, but he had what is now called focal fibromuscular dysplasia, not the string of beads type, but the focal variety. From about 1938 until 1970, nothing was done. And then in the 70s, there was a lot of information. Now, just so everyone is on the same page, this is a renal angiogram, kidney artery, and you can see the typical string of beads in the most common type of FMD called multifocal FMD. And this beading is caused by little webs that occur in the artery here. And these little webs cause turbulence to flow, and they cause narrowing of the blood vessel. Here's just another example of a less severe form, but nonetheless, it can affect the branches to the kidney. And it really can affect any artery in the body. So what is shown on this slide actually was not known when we first started getting into this. This is multifocal FMD on the top left. Next to it is focal FMD. This occurs in younger women, usually around the age of 25 to 30, but can occur in people up to the age of 60. This shows arterial tortuosity or curviness of the artery. On the top right, you see a dissection of the artery, a tear in the artery. Bottom left is the coronary artery, or so-called SCAD, spontaneous coronary artery dissection. And then the three images on the bottom to the right side are aneurysms. All of this can occur in fibromuscular dysplasia. Now, how did I get into this? I was originally trained in internal medicine, hypertension, and nephrology. And on this slide, you see three of the most famous hypertension people in the world: Irvine Page on the Time magazine, Harriet Dustin, and my mentor, Ray Gifford. Ray Gifford was the chair of the Department of Hypertension and Nephrology at the Cleveland Clinic, and he was an incredible guy. He was actually one of the first vascular medicine people. Everyone called him Dub. He was just unbelievable. He was a very thoughtful person. He was a loyal friend, and he really had an impact on my career. And his patients loved him. He spent a lot of time with his patients, and he could think like he was a Harvard professor, and at the same time, he was like a folksy country doctor. He's one of the best doctors I know, and he really had an influence on my career. He was not a lot of fun to be around if Ohio State lost the football game, though, especially if they lost to Michigan. The other person who had a major impact on my career is Jess R. Young. Dr. Young was the chairman of the Department of Vascular Medicine before I became chair, and he and I collaborated on a lot of work. We wrote 2 volumes of this textbook, and he was the consummate physician as well. So I kind of switched gears from hypertension and nephrology to hypertension and vascular medicine. My introduction to FMD was when I was in the nephrology department because it affects the kidney arteries. And then I further developed this when I was in vascular medicine. And this is me giving, I received the first Jess R. Young Teaching Award for outstanding vascular medicine education in 2010 or so, and I was talking about FMD here. Now, before I start into the FMD stuff, I want to show you a few quotes because everybody asks me, why can't we just get an answer? Why is it so difficult? Well, when I was a fellow, almost everything I thought I knew about FMD was incorrect. And I was training with the smartest people in the world from Mayo Clinic and Cleveland Clinic. But a lot of it just was not known. So if you want to be successful in research, you need to have some kind of creativity, and you need to let go of what you think is correct and follow the guidelines of what's scientifically correct. Now, Sir William Osler was one of the most famous early physicians. He has a lot of quotes, but this really applies to the FMD patient. The good physician treats the disease. The great physician treats the patient who has the disease. And you all know that many physicians don't pay attention to what you guys are saying, don't pay attention to the mental health aspects of this or other aspects of this disease. I smile at obstacles. I can't say that I'm actually do this, but Tiger Woods does. He likes it when he has to overcome obstacles. And this is my favorite quote. I've missed more than 9,000 shots in my career. I've lost almost 300 games. 26 times the game was on the line and I had to take the winning shot and I missed. I failed over and over and over again in my life. And that's why I succeed. So in this business, it's not going to be all success as you're trying to do research and figure out what the best treatment is for this condition. In 2014, the American Heart Association agreed to allow us to write this state of the science paper. And at the time, this is a multidisciplinary document with vascular surgeons, cardiologists, neurologists, interventional radiologists, and we came together to talk about what was known about this condition and what questions we need to ask. In 2019, the first international consensus document on the diagnosis and management of fibromuscular dysplasia was undertaken. And this was with the group from Europe, Eastern Europe, Western Europe, and the United States. So I want to get into FMD and what it really is. This is multifocal FMD, the so-called string of beads. This is a kidney artery. The one in the middle and on the right are carotid arteries. And this is focal FMD. I saw one of the questions, someone asked something about intimal disease. Well, this is what used to be called intimal fibroplasia. On the left is a carotid artery, and then the middle and the right hand are renal arteries. So it can produce like a concentric band causing a severe narrowing of the artery, or it can cause a tubular stenosis. So in 2004, because of some early work that we did, my fellow at the time was Dr. Slovit. He and I wrote this paper in arguably the best clinical journal in the world, the hardest to get published in, and this was the New England Journal of Medicine. And it shows you how you have to constantly be learning. In this table, we said that 60 to 75% of people had renal artery involved, but only 25 to 30% of people had the carotid or vertebral arteries involved. Well, this was not correct. The reason this was not known and why everybody said 25 or 30% is nobody looked at the carotid arteries. Once we started looking there, just as many people had involvement there as they had elsewhere. 28% in this paper had multivascular bed involvement. We know it's twice that amount now. So this entire table was wrong, published in the best journal available, underwent peer review, and it just goes to show you that what you think is correct may not be correct if you keep looking and investigating. Did the New England Journal of Medicine paper lead to millions of patients coming to our clinic to be evaluated for FMD? Absolutely not. Doctors still didn't know anything about it, but this did. The Wall Street Journal article. Pam, in a large part, is responsible for this. On the left is Pam. I'm in the middle. On the right is Rochelle Durocher from Toronto. And this really put fibromuscular dysplasia on the map. Tom Burton, who wrote this, won the Pulitzer Prize for some of his work on abdominal aortic aneurysms. And actually, within about 10 minutes of this being published, I was getting emails from people in Australia, South Africa, and other parts of the world. People say this is a rare disease. This is not a rare disease. It's rarely diagnosed. If you look at potential kidney donors, 4% of them have fibromuscular dysplasia. These are normal people. That's more than 5 million women in the US. But what really gets me is this study. This was a study looking at treatment of narrowing of the renal artery due to atherosclerosis. If you had FMD, you were not allowed to be in this study. It was an exclusion. So the patient's on the table, an angiogram is performed, and then they're randomized to receive either a stent or medical therapy. Then the images are sent to a core lab, University of Virginia, Alan Matsumoto, and they're overread. And when the core lab overread the images, they found that 9% of the women in this study, 500 women, had fibromuscular dysplasia and should not have even been in this study. And the average age was 71 years. So this is not just a disease of young women, it's a disease of young, middle, and older women predominantly, and it's seriously underdiagnosed. Why do people not pick up carotid FMD? Because they don't listen to the neck most of the time. And if they do, I ask my patients always, has anybody ever listened to your neck? This image on the right with the red arrow shows you a very severe narrowing. This patient heard a swooshing sound in her ear. And you could hear the bruit without a stethoscope in this patient. The image on the left is where you don't want to listen. This is not the right location. You want to listen up here if you're going to hear a bruit. And many physicians don't do this and don't know about this. So with the help of Pam and a steering committee, the steering committee was Heather Gornick and Jim Freilich and Eva Klein-Rogers and Chao Kui Gu and Pam. We started the United States Registry for Fibromuscular Dysplasia, and this is where we really started learning some things. And this was our first publication in the first 447 patients. We now have over 3,000 patients in the registry, and we're updating our data to see if our early results are staying the same. The average age at entry was 56 years old. The average age at diagnosis was 52. I was always taught it was a disease of 20 and 30-year-old women. 91% were women. Now it's up to about 95%. 95% are white, but this is selection bias. The patients who are educated and have the means to travel go to an FMD center, and the patients who don't have the means to travel and are uneducated don't. So it's a selection bias in who actually enters the registry. These are the most common presenting symptoms. High blood pressure. Well, 100 million Americans have high blood pressure. Not everybody has FMD. Headache, most commonly migraine headaches, pulsatile tinnitus in more than a quarter, that's that swooshing sound, and dizziness. And then there's a host of other signs and symptoms. So if the carotid artery is involved, which it is 73% of the time or so, patients get headaches, pulsatile tinnitus, dizziness, face or neck pain, and a bruit when if a doctor or healthcare provider listens to the neck. The vertebral artery, the artery that supplies the back part of the brain, headache, pulsatile tinnitus, dizziness, neck pain, and bruit. If the kidneys are involved, 75% have the kidneys involved. The most common sign is high blood pressure. Patients, if they have a dissection of that artery, they can get flank pain or a bruit. So these are the most common manifestations. Now, the group from Paris, we've collaborated with them a lot, and they published a really fantastic paper in 2012 showing the difference between those who have focal FMD and those who have multifocal or string of beads. And the basic difference is this. Focal occurs in very young women. The average age at diagnosis of high blood pressure was 26. The average age at diagnosis of FMD was 30. There's a 4-year delay from onset of hypertension to diagnosis of FMD. If you look at those with multifocal FMD, the average age of onset of high blood pressure is 40. The average age at diagnosis of FMD was age 49. So there was a 9-year delay from the first symptom until the patients were diagnosed with fibromuscular dysplasia. Most individuals who have focal disease undergo angioplasty. Only a third of those who have multifocal disease undergo angioplasty. And the reason is you don't need to do angioplasty because the blood pressure is easy to control in the large number of patients. Not everybody, but the majority of patients, it's easy to control. Now, my colleague and partner, Dr. Katie Dodolph, published this paper from the registry, 966 patients. And this is where we really showed and changed the paradigm of how these patients are investigated and treated. This is an aneurysm, an enlargement of the artery. This is a kidney artery. This individual has 3, 4, 5 aneurysms here. And here we can see aneurysms on this CT scan. And in our initial series, 22% of patients had an aneurysm. At Mount Sinai, where we have been doing chest, abdomen, and pelvis CT angiograms, and neck and head CT or MR angiograms, 35% of our patients have an aneurysm. So this has led to the suggestion that every patient with fibromuscular dysplasia should have a one-time head to pelvis imaging with CT angiography if you can do it. And the aneurysms occur in the kidneys, the carotid arteries, intracranially, brain aneurysms, and even the aorta. These are predominantly young women who are never smokers. This is a very high rate of aneurysm. This is an intracranial aneurysm. The red arrow points to the anterior communicating artery. And we published this paper showing that in this series of over 600 patients, that 13% of them had at least one intracranial aneurysm. And here's just some examples of various things. The top middle shows a pseudoaneurysm in a patient who had a tear or a dissection in the artery. The red image is a bilobed basilar artery aneurysm in the brain. The other thing that we've discovered is that there's a high rate of dissection of the artery as well. Dissection is a tear in the artery. Here's ultrasound showing a carotid dissection on top and a vertebral artery dissection on the bottom. See, there are two channels that blood is flowing through. There's a tear in the artery, and the most common places are the carotid or vertebral arteries. What we didn't know at the time, which we now know, is that coronary dissection, or SCAD, occurs much more commonly than we think. And SCAD is one of the manifestations of FMD. Not every patient with SCAD has FMD, but the genetics of it are very, very similar, as I'll show you towards the end. And here's what you can do with ultrasound. If you can see the beading on the left, you can see the area where there's a dissection. We are imaging very high up above the ear. So most ultrasound labs just look in the neck. So if you have FMD, you want to make sure that whoever's doing the ultrasound is looking in the right place for the fibromuscular dysplasia. Now, what about the coronary manifestations of FMD? So we published this paper a few years ago. Jason Kovacic is in Sydney, Australia. He's the executive director of the Victor Chang Cardiovascular Research Institute. He was at Mount Sinai for many years, and he and I are doing the genetic study, or the defined study, of fibromuscular dysplasia. So here are what you can see in the coronary arteries. This is a dissection on the top left. The top right, you see tapering of the artery. This is the hardest one, the bottom left. This is an intramural hematoma. In other words, you don't see a tear, but you see a collection of blood around the artery, causing a severe narrowing of the artery. And then here we see what's called arterial tortuosity, or curviness of the artery. And on the left, you can see the tear in the coronary artery here. On the right, this is an optical coherence tomography. We have this catheter inside the artery. It's an ultrasound, but it's really OCT, and you can see the true lumen, you can see the tear in the artery, and you can see the false lumen there. It gives you very, very high resolution. When you see something like this, everything looks good when you first look at it, but then you see this artery, you see a hinge point, you see a long, smooth narrowing, and then the artery comes back to normal. That's dissection. And it's missed very frequently by interventional cardiologists who are doing a cardiac cath in a 40-year-old woman with chest pain. So in patients who have fibromuscular dysplasia, in our series, when we looked at about 1,000 patients, 42% had an aneurysm or a dissection somewhere in their body. And thus, it's imperative that you look from head to pelvis with good cross-sectional imaging. Now, what percent of people with SCAD, coronary dissection, have FMD? This is from Jackie Saul's study. She had about 62%. It depends how carefully you look for it, but somewhere between 50 and 75% of people with SCAD have fibromuscular dysplasia. And many of you know this, that if you can get away without doing anything, if you have SCAD, you should not do anything, meaning that angioplasty in patients with SCAD is dangerous. And so the only time we would consider doing an angioplasty or surgery if the flow is severely restricted to the heart muscle, and that's called TIMI 0 to 1 flow. If you have good flow, you leave it alone, and almost all these dissections in the artery heal. Fortunately, only about 30% of people have TIMI 0 to 1 flow and need to have something done. 70% of people have good flow when they have a coronary dissection, and you can just treat them medically. This just shows tortuosity of the coronary arteries, and this is associated with a higher rate of recurrence of SCAD, but otherwise really doesn't cause any problems. So the primary manifestation of coronary FMD is spontaneous coronary artery dissection. Arterial tortuosity may be seen. You do not see the string of beads or focal disease in the coronary artery. Thus, stress tests are of no use to determine if you're going to have SCAD. You have to do a cardiac catheterization at the time of symptoms. There's no other way to predict whether or not a patient is going to have SCAD or not. Now, I want to just briefly mention a couple of misconceptions. One is, now, many of you have been through this, where somebody tells you your carotid artery is narrowed 60 to 70%, or that it's narrowed 70% and you need to have a stent placed. Well, these are all falsehoods. When you have the string of beads type of FMD, like I'm showing you here, you cannot tell how severely narrowed the artery is. In fact, the one on the bottom left looks the most mild to me. The one on the top left looks the most severe to me. What we do is we measure pressure before and after the area of beading. The pressure should be the same. If it's 100 before the beading, it should be 100 after the beading. Here, the pressure is 100, but on the other side, it's 70. So there's a gradient of 30. This is the only way you can tell whether or not an artery is severely narrowed with the string of beads type of FMD. So you can't give it a percentage for a renal artery or a carotid artery, and anyone who does not understand this disease. Now, I just want to stop this for a minute. This on the left is an angiogram, and you can see this very severe narrowing with areas of dilation. On the right is OCT, optical coherence tomography. Here's the catheter in the middle. This big black area is the artery. You're going to see this artery get bigger and smaller. You're going to see these little webs pop out. And towards the end, you're going to see a dissection in the artery that you can't see on the regular angiogram. So let's take a look at this. The artery is huge now. Look how big it is. We're pulling the catheter back. You're going to see little webs pop out there. The artery, very narrow there. It's opening up again. There's the dissection. So this gives you the best view of what's going on with the artery. And actually, you can see things that you can't see with any other imaging technique. Now, this was a 26-year-old woman. She's about 36 now. And she had a 3 or 6 month history of really severe hypertension. And her doctor made this diagnosis right away. We did this angiogram on her. You can see The right kidney artery is severely narrowed. The left looks pretty good, right? So we did an angioplasty of the right, looks perfect. And if we stopped there, her blood pressure would not have been cured. This looks normal on the left side, but you have to put a wire through it and measure the pressure gradient. And that's what we did. We put a wire through there. Now you can see a little indentation there. And this area has a 50 millimeter mercury pressure gradient, meaning if we left that, we would have thought that our angioplasty was unsuccessful and her blood pressure would not have been cured. She has had normal blood pressure on no medications. This is what you can expect with focal fibromuscular dysplasia. Younger women, shorter duration of high blood pressure, you can expect a cure a large percentage of the time. Now, the reason we say you don't put stents in, this is Heather Gornick's slide. This renal artery is lined with stents. As the kidney goes up and down, it rotates. And so it puts enormous stress on the stents. And actually, there's a stent fracture here. So we only put a stent in a kidney or carotid artery if we cause a dissection or if there's a dissection present. I just want to mention arterial tortuosity. You can see this in a carotid artery here. This is part of the FMD phenotype. So we had noticed that people were having more and more, we were noticing tortuosity more and more in people with FMD. So we decided to formally look at this. Sanjam Sethi was a resident in internal medicine at the time we did this study. And we published this paper, The S-curve, a novel morphologic finding in the internal carotid artery in patients with fibromuscular dysplasia. Now, what is the S-curve? This on the left is a reverse S-curve. On the right, you see real-time imaging. You see the carotid artery is in the shape of an S. And this means there's extreme tortuosity. This is never normal in someone below the age of 70. It's not specific for fibromuscular dysplasia. You can see it in other diseases like Marfan syndrome, Loeys-Dietz syndrome, vascular Ehlers-Danlos syndrome. But it's very common in people with FMD, occurring in about 30% or so. Now, many of you ask me, 50% of the people who come to see me referred or self-referred with FMD don't have it. And many of those patients have what we call an FMD-like syndrome. Let me just show you this example of 3 sisters. Sister 3 had string of beads FMD of the carotid arteries, spontaneous coronary artery dissection of the mid-LAD, left anterior descending coronary artery, and mild enlargement of the celiac artery. Sister 2 had multifocal FMD of the carotid arteries, multifocal FMD of the right renal, left renal, and left accessory renals, and multifocal FMD of the internal and external iliac arteries. Sister 3, who is actually who I saw first, had extremely tortuous S-curve carotid arteries and a splenic artery aneurysm. Now, she has FMD, but we only know that because her sisters have it. We cannot put her in the registry. She does not meet the criteria for the registry. You have to see the string of beads in order to be put in the registry. But I wrote this editorial a few years ago called The Expanding Clinical Phenotype of Fibromuscular Dysplasia. And these FMD-like patients have everything that patients with FMD have, but they don't have the string of beads. And Alexander Pursue from Brussels, Belgium, Heather Gornick from Cleveland, Ohio, and myself are in the process of writing a paper on FMD-like patients and how they compare to patients who have fibromuscular dysplasia. Now, I just want to finish up in the next couple of minutes with just a few words about the genetics. So in 2015, Stephanie Debet, who was in Paris at the time, she's a stroke neurologist, a brilliant woman. She published this paper called Common Variation of PRACTA1 is Associated with Susceptibility to Cervical Artery Dissection. So she identified a gene locus that makes people susceptible. Now, this differs from a gene like in Marfan syndrome, where you have the FN fibrillin 1 gene and you have Marfan syndrome. FMD is not like that. It's a multi-genetic disease. But having this increases the likelihood that this patient is going to have a carotid or vertebral dissection. A few years later, we published with the group from France this paper in PLS Genetics. PRACTA1 is a genetic susceptibility locus for fibromuscular dysplasia, supporting its complex genetic pattern of inheritance. And last year, we published this paper in the Journal of the American College of Cardiology, the association of PRACTA1, EDN1 gene locus with spontaneous coronary artery dissection. So as you can see, there's a genetic linking of these three conditions, which actually may be one condition if we get down to it and learn a little bit more about the genetics. Oops, sorry. So PRACTA1 is associated with FMD. PRACTA1 is associated with cervical artery dissection. PRACTA1 is associated with SCAD. And I didn't show you this data, but it's associated with migraine headache. So we started the DEFINE trial. Now, it's very, very hard to do research in FMD because there's virtually no funding available. All of this research was funded by one or two individuals. And we would not have been able to do this if we didn't have that funding. We are talking about several $1 million to do what we've done so far. We desperately need additional funding to consider this research. So basically, we're looking at DNA, the genetic backbone. DNA makes RNA, and RNA makes proteins which cause a various biologic effect. The vaccine for COVID is going to be a microRNA related vaccine. So we started the DEFINE trial. I run the clinical part of that trial. Dr. Kovacic runs the genetic part of that trial. We take blood. We take a piece of skin from the back of the arm. Many of you have participated in this. This at the bottom right is skin. All these other things are fibroblasts. We grow about 7 generations of these fibroblasts. And then we look at the RNA, we look at the proteins, we stimulate these, we deprive them of food, we put them in all kinds of adverse conditions, and we look at what they produce. So we harvest these, we extract the RNA, and we quantitate between 50,000 and 100,000 genes. Valentina in Dr. Kovacic's lab is still here at Mount Sinai, and she is the one who really handles all of the skin biopsy and the fibroblasts. And we've enrolled 402, 209 patients, and 231 controls. Interestingly, before a patient can be a control, they have to come in. They have to be evaluated by one of us. We take a history. Do you have a migraine headache? Do you have swishing in your ear? Do you have high blood pressure? We listen to their neck and their belly. We've now identified 4 people who have come in to be controls who ended up having fibromuscular dysplasia. That's crazy. So she handles all the fibroblasts and processes and biobanks all of this information. Now, this is what we're looking at. If you don't understand this, don't feel bad, because I don't either. This is the types of information we get back from these genetic studies. This is just mind-boggling. And no human can analyze this. This all has to be done by artificial intelligence and mathematicians, et cetera. The first paper that came out of this, we published in 2019 in Cardiovascular Research. It's the research journal of the European Society of Cardiology, and it's called a plasma proteogenomic signature for fibromuscular dysplasia. And we identified proteins that, that occur in a high likelihood. And the goal will eventually be where we can do a blood test and say, yes, you do have FMD, or no, you don't have FMD. We're not there yet. We're about 70% accurate here, but you have to be closer to 100% accurate. This is our team. On the left is Catherine Michaelis, who was a cardiology fellow when we wrote the coronary manifestations of FMD. Annette King is my nurse practitioner extraordinaire. Valentina handles all the specimens. This is Dr. Kovacic, and this is my partner, Dr. Daniela Kadian Dodolf. And we collaborate with the FMDSA. They support our, and you all support the US Registry. We collaborate with the group in Paris. We are associated with the SCAD Alliance. And now that Jason is at the Victor Chang Cardiovascular Research Institute, we collaborate with them. So I think I will stop there. And I will stop sharing my screen and hand it over to you, Pam.
Okay, hi everyone. Dr. for that wonderful presentation. I think we had probably 20 more people sign on while you were speaking, so I muted myself.
Yeah, we have 281 people on.
Yeah, so that's pretty amazing. So again, I'd like to thank you, and we're going to take some questions. We have a lot. Before the Zoom even started, we had received probably 100, and I was